So thank you for attending this session. So we have a very wonderful set of speakers here, so both empirical and theoretical. So actually, I'm Zhao Wei. I'm going to be the first presenter. So in case so to be on time, I will just present a pre-recorded video for my talk. So let's hear it now. So. Okay. Hello, everyone. Thank you for attending this session. My name is Zhao Wei. I'm currently a PhD candidate in operation research from Georgia Tech ISYE. This is a work study in the Medicare Advantage program in the US. So specifically, Medicare Advantage is a government-sponsored while private-run healthcare insurance program in the US. It is government-sponsored in the sense that the US government uses tax money to sponsor these programs so that most of its eligible beneficiaries can afford to join these programs. And it is privately run in the sense that it is the private insurance company instead of the government agency who are actually running or managing these programs. So the expectation or hope is that this kind of private insurance company are more efficient in terms of their healthcare deliveries. And one of the motivations for us to study this topic is indeed to empirically examine whether this kind of statement is true, whether this private insurance company are indeed more efficient in terms of healthcare delivery compared to the public programs. So just give you a little bit more background. Medicare Advantage is part of these Medicare programs, which is the largest healthcare insurance programs in the US. So basically for every Americans, when they turn age 65, they become automatically eligible for this kind of Medicare benefits. And also, they have a choice here. So they can either choose to access this kind of Medicare benefit through traditional Medicare, where they will join a public health plans directly managed or run by the government agency called CMS. And alternatively, they can also join the Medicare Advantage programs, where they will be joining these private health plans paid by the CMS. That is, the US government will cover most of their premium to join these health plans. However, these health plans are managed or run by this kind of private company instead of the government agency itself. So more precisely, so what the CMS does in these Medicare Advantage programs is simply to outsource all of these healthcare deliveries and management work to these private MA health plans through these capitation payments. That is, the CMS pay these MA health plans a fixed amount of money per patient per year based on the estimated healthcare costs of these patients during these years. And these MA health plans will take these capitation payments to contract with physicians or hospitals and to provide healthcare service to their enrollees. So therefore, as you can see, this MA health plan indeed has a very large degree of flexibility in terms of how to spend these capitation payments. And the research objective of these papers is indeed to empirically characterize or investigate how does this MA health plans spend these capitation payments in terms of providing healthcare service to satisfy the healthcare needs of their enrollees. So, more specifically, the first research questions we are going to ask in this paper is that, is there a systematic difference between the way of healthcare delivery or healthcare spendings between these MA health plans and the public program in traditional Medicare? There are some preliminary evidence saying that at least in certain services, there is this kind of difference in healthcare spending between these programs. So for example, if you look at these two medical papers, as they are both published in these top medical journals, so the first paper is published in New England Journal of Medicine, it finds that MA health plans tend to spend more to provide this kind of benefits such as free gym membership to their enrollees, while those Medicare beneficiaries enrolled in traditional Medicare do not have access to this kind of free gym membership benefits. Therefore, it turns out that at least MA health plans are spending more on this kind of gym membership service. However, on the other hand, this health affairs article finds out that MA health plans have been spending less in this kind of nursing home service compared to CMS in traditional Medicare. So it finds out that the quality of nursing home service are in general lower than the quality of nursing home service in traditional Medicare. So it turns out that at least in certain services, MA health plan has been overspent compared to what CMS has in traditional Medicare, and in other kind of services, MA health plan has been underspent compared to the spending level in traditional Medicare. And this is the first research question we are going to study, is that whether in general, MA health plan has been systematically overspent in certain areas and systematically underspent on the other areas. And then the second questions we are going to ask in this paper is that if we indeed find out that there's a systematic difference in healthcare spending patterns between MA and TM, and what is the cause of this kind of systematic difference? So what is the underlying mechanisms for this MA health plan to have a different way of spending these, allocating healthcare resources compared to CMS in the public programs? So in order to answer these questions, what we have is a very large and comprehensive claims database from the United Healthcare, which is the largest MA health plan providers in these Medicare Advantage markets. So with these data, let's first answer the first questions. That is there a systematic difference in this kind of healthcare spending patterns between MA and TM? So what we do here is that we have a dependent variable which is measuring the spending difference for certain patient I in EAT, which this dependent variable we call the MA-TM gap. And we want to see whether where there's a systematic gap for patients of different risk scores. That is, for patients with different health conditions. So if there are no systematic difference between MA and TM, basically, we are going to expect that these coefficients is not statistically different from zeros. Otherwise, we may say that there's certain kinds of difference between different patient groups in terms of how MA health plans has been spending this kind of capitation payments. And indeed, through running these regressions, we basically confirms our first main hypothesis. That is, there is a relative association between the sick list of a patient and the MA-TM gap of these patients. That is, as these patients become sicker, as the risk score of this patient increase, we indeed finds out that these MA health plans have been spending less on these patients compared to what would have been the spending levels on these patients in traditional Medicare. So that's basically answers our first research questions, saying that there seems to be indeed a kind of systematic difference between this kind of MA spending and traditional Medicare spending. And that leads to our second questions. So what drives this difference? So what we hypothesize here is that the second main hypothesis is that this kind of likely association we have just observed between risk score and the MA-TM gap is caused by a mechanism we call reverse subsidization mechanisms. That is, we hypothesize that the MA health plans has been reallocated part of the capitation payments collected from the sicker patients and use it to cross-subsidize the healthy patients to provide some extra benefit or service to these healthy patients, such as gym membership, and to see how does this kind of reverse subsidization practice can actually cause this kind of negative association we just observed. Let's just look at these pictures. Basically, what we hypothesize here is that there are certain amount of capitation payments which should have been spent on these high-risk patients. So without cross-subsidizations, basically what we should observe is either a flat associations or even a positive associations between this risk score and MA-TM gap. However, the reason that we have been observing a negative association between this risk score and MA-TM gap, it is because these MA health plans has been reallocated part of this capitation payment, which is supposed to spend on high-risk patients, and use it to cross-subsidize the low-risk patients to provide some extra benefit to these low-risk patients. And that is our second main hypothesis. And I also want to mention that I also have a theoretical paper which explains why this MA health plan have incentive to do so. So if you are interested in that papers, please go on my website to check out that papers. However, in terms of what we want to do in this paper is basically to empirically identify this kind of reverse subsidization mechanisms and test whether these negative associations can actually caused by these reverse subsidization mechanisms from the data. So one thing we want to emphasize is that we cannot simply say that, okay, we observe a negative association between this score and MA-TM gap. Therefore, we have some kind of evidence to say that there's a reverse subsidization behavior happening in this MA market. Why? Because this kind of lactic association can obviously caused by other kind of mechanisms, such as this this kind of measurement error in risk score, such as or this kind of systematic difference in this technology between MA and TM. Probably MA health plan are just more efficient in taking care of these high-risk patients compared to traditional Medicare providers. Therefore, in order to empirically separate this kind of alternative hypothesis from our main hypothesis, and to empirically identify the reverse subsidization practice, what we use is a policy shock from the Affordable Care Act. So in 2010, when the Affordable Care Act was passed, and large amount of money were basically taken away from the Medicare programs, which results in a significant reduction in this kind of MA capitation payment. And a more peculiar fact is that this kind of reduction in MA capitation payments is actually having an asymmetric impact on different type of patients, especially those patients with high risk score. Those sicker patients are actually receiving less money and have a deeper capitation payment cut compared to those relatively healthy and patients with no risk scores. And this kind of asymmetric impact of this ACA cut can actually help us to empirically separate the two alternative hypotheses from our main hypothesis and to empirically identify the reverse subsidization practice. So to see how, first, let's just assume that this kind of lactic associations is not caused by anything due to this kind of reverse subsidization practice. And in this case, what we expect is that after this ACA capitation payment cut, you will be observing an even more steeper lactic association compared to the before ACA level. Why? Because in the ACA cut, the sicker patients' capitation payments has been cutting much deeper compared to the low-risk patients' capitation payments. In this case, the MA health plan has even less incentive to spend on these high-risk patients, which you expect that to result in a even more steeper lactic association compared to the before ACA cut level. However, in the other scenario, if you believe that the lactic association is caused by something related to these reverse subsidizations, actually you will have a different story. So indeed, it is correct that this kind of high-risk patient receive more capitation payment cut. However, this capitation payment for high-risk patient under this reverse subsidization story are not used on this high-risk patient in the first place anyway. They are used to cross-subsidize these low-risk patients. Therefore, if you believe in this story, this kind of ACA capitation payment cut is actually going to affect this low-risk patient more, because this low-risk patient not only receive less capitation payment, they also receive less reverse subsidizations. Therefore, our identification strategy can be basically summarized by these pictures. Basically, in order to empirically identify the reverse subsidizations, basically we want to show that after the ACA cut, the lactic associations have been becoming more flattened compared to the before ACA level. And the one last thing we want to do here is that we want to randomly assign this ACA cut across otherwise similar patient group so that we can indeed make this kind of causal claims. And how do we be able to randomize this kind of ACA cut? So what we exploit is this staggered rollout of this ACA cut across US county during this ACA periods. Basically, what the government do is that they have a projected ACA cut for each county, and for those counties with higher number of projected ACA cut, they will face in this ACA cut in a much slower fashion, while those counties with lower projected ACA cut, they will face in this cut in a much faster fashion. And basically, what we exploit from this paper is to explore this policy determined cutoff and study the delta neighborhood around this cutoff to assign a treatment and control group a study design similar to geographic regression discontinuous design in the literature to basically help us to randomize this ACA cut across different patient groups and obtain this treatment and control assignment. So with that, we can finally test our hypothesis. Basically, if you're expecting this lactic association to becoming more flattened after ACA cut, basically you are expecting this interaction term to have a different sign compared to these slope terms. Therefore, when they add them together, you will get the more flattened negative associations. Alternatively, if you expecting that this slope will become more steeper, so the negative associations have nothing to do with reverse subsidizations, you will be expecting that this interaction terms to have the same sign as the slope term. So you have, when you add them together, you will have a more steeper lective associations. And in our final result, we're going to show here, basically we explore different delta neighborhood around that $30 cutoff, and all of these different specifications gives us a consistent result, saying that this interaction term is indeed of the opposite side of these slope terms, which means that after the ACA cut, we indeed have a more flattened lective associations, which confirms our second hypothesis. So to sum up, in this paper, basically we empirically identify this overspending and underspending behavior in MA health plans through this kind of geographic regression discontinuity design, and provide the first evidence of reverse subsidizations in healthcare. So so that's all. Thank you very much for listening. So if you have any questions, please ask me now or send an email to my email address. I'm very much looking forward to hearing from you. Thank you.